You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 3rd, 2021. This week will be a European Society of Cardiology meeting wrap-up. I'll probably take 2 to 3 weeks to get through all of the studies at ESC. First, COVID. I'm not saying a word about COVID today. Let's just move to cardiology. The first is, of course, Emperor Preserved. This was empagliflozin versus placebo in heart failure with preserved ejection fraction. The SGLT2 inhibitors have been proven beneficial for the reduction of CV events in type 2 diabetes, the reduction in renal outcomes and chronic kidney disease, and a reduction of heart failure hospitalizations and CV death in heart failure with reduced ejection fraction. Emperor Preserved was the first randomized controlled trial testing SGLT2 inhibitors, empagliflozin, in patients with heart failure with preserved ejection fraction. The primary endpoint of this trial was time to first hospitalization for heart failure or CV death. Recall that Paragon-HF, the most recent heart failure preserved ejection fraction, this was a trial of sacubitril/valsartan versus valsartan, studied total heart failure hospitalizations or CV death. That's a little bit different endpoint. Emperor Preserved investigators screened more than 11,000 patients to randomize 6,000. That's kind of important because all trials carefully select patients, but Emperor Preserved excluded almost as many as they randomized, and most of these patients were excluded because they did not meet a threshold for BNP. The average age in this trial was 72, about half were women, and 1/3 had slightly decreased left ventricular ejection fraction of 40 to 50%. So it wasn't all totally normal EFs in Emperor Preserved. What were the results? At slightly more than 2 years of follow-up, 13.8% of patients in the EMPA group experienced CV death or heart failure hospitalization, compared with 17.1% of the placebo group. The 3.3 percentage point absolute risk reduction translated to a 21% relative risk reduction, and the result was statistically robust with a p-value of 0.003. Now you should now be asking what happened with the two components of the endpoint. You'd like the drug to reduce both. Well, heart failure hospitalizations was reduced by 29%, but CV death was only reduced by 9%. The heart failure hospitalization rate was statistically significant, but the CV death reduction did not reach statistical significance. Now, before I comment on these results, let me tell you about a second presentation given at ESC and also published in the New England Journal of Medicine. Dr. Milton Packer presented what's called an, quote, Emperor pooled analysis of renal outcomes. The pooled part is the combination of Emperor reduced, which was EMPA versus placebo in patients with heart failure with reduced ejection fraction, and Emperor preserved. Dr. Packer points out that the two trials were sort of sister trials, similar protocols, sites, infrastructure, and the difference between the two trials was simply ejection fraction of 40%. Above it, and you got in preserved. Below it, and you got in Emperor reduced. The pooled analysis was interesting. In Emperor reduced, the drug reduced a composite renal outcome by 50%, whereas in Emperor Preserved, there were no reductions in renal outcomes. Now, my summary here is that Emperor Preserved gets to be the first truly positive trial in heart failure with preserved ejection fraction. And since many patients with HFpEF also have CKD type 2 diabetes, there are going to be good reasons to use SGLT2 inhibitors, specifically empagliflozin. Now, there is a placebo-controlled trial of dapagliflozin versus placebo in heart failure with preserved ejection fraction coming soon. That will be a very important trial. But I think, my friends, the buzz over this drug and this condition is overdone. And here's why. The really only signal of benefit in Emperor Preserved was in heart failure hospitalizations, not CV death or all-cause death or renal outcomes. You say, come on, Mandrola, heart failure hospitalizations is an important outcome. And I'd say, yes, preventing admissions for heart failure is important, but only if heart failure hospitalizations represents a big chunk of all-cause admissions. Go to Table 3 in the New England Journal of Medicine paper, and it turns out that in this group of patients who happen to have tons of other medical problems, heart failure hospitalization represents less than 20% of all hospitalizations. The number of heart failure hospitalizations in the EMPA arm, 407. The total all-cause admissions, 2,566. Pause there and think about this. We're about to accept an expensive drug based on an endpoint that represents a very small fraction of the total reasons this group gets admitted to the hospital. Later in the podcast, I will discuss another trial of heart failure in which heart failure hospitalizations represent nearly 90% of all-cause heart failure. And when that is the case, heart failure hospitalizations is a good endpoint, but not so much in a condition like heart failure with preserved ejection fraction. These patients have multiple morbid conditions. Also, the lack of improvement in renal outcomes makes me think that empagliflozin acted simply as an expensive diuretic, not an important disease-modifying drug in this group of patients. Well, finally, the mean difference in the KCCQ, which is a questionnaire that goes from 0 to 100, and it measures quality of life, was less than 2 between EMPA and the placebo group. Most people feel that a meaningful change in KCCQ is 5. So EMPA clearly underperformed on quality of life measures as well. Now, I'm a big fan of SGLT2 inhibitor drugs, but Emperor Preserved fails to convince me that we should accept such an expensive drug in the absence of reductions in CV death, all-cause death, renal outcomes, and quality of life. Yes, there will be patients with heart failure with preserved ejection fraction who also have CKD or type 2 diabetes, or let's just say a patient with an ejection fraction hovering around 40%, whom I might consider SGLT2 inhibition for. But a blanket recommendation to treat all HFpEF patients with EMPA, I think, would be unwise and wasteful of precious healthcare dollars. Next topic is the LOOP study. Now, to date, nearly all AF HFpEF screening studies have found that if you screen older patients who have risk factors for stroke, if you screen them for AFib with any technique, ECGs, pulse, iPhones, you can show more AFib episodes and more anticoagulation prescriptions in the screen group. But finding more AFib and initiating more anticoagulation is not the endpoint that matters. The endpoint that matters, the core reason we use anticoagulation in AFib, is to reduce stroke without increasing major bleeding, so-called net benefit. Indeed, one of the reasons I was drawn to the LOOP AF screening study that was presented at ESC was that it measured stroke and systemic embolism as its primary outcome. LOOP enrolled patients who were about 74 years old, mean CHA2DS2-VASc score about 4. 1,500 patients were randomized to an ILR. 4,500 patients got standard care via primary care in Denmark. Any atrial fibrillation greater than 6 minutes in either group prompted a recommendation for anticoagulation, and most patients accepted that. Now, the first thing to say about the results is that AF was detected in 32% of the ILR group versus 12% of the control group. That's more than 3x different. And this led to nearly 3x more use of anticoagulation in the ILR group. Follow-up was 5 years. My friends, what do you think happened with this sort of difference in AFib and anticoagulation use? Remember, mean age 74, CHA2DS2-VASc super high at 4, 3 times more anticoagulation, And yes, indeed, stroke was reduced by 20%. 4.5% of the ILR group had a stroke or systemic embolism versus 5.6% in the control arm. The hazard ratio was 0.80, and the 95% confidence intervals ranged as low as 0.61, a 39% reduction, to 1.05, a 5% increased risk of stroke. And sadly, the p-value was 0.11. This means the reduction in stroke did not reach our threshold significance of 0.05. If there was truly no difference in the two groups, aka the null hypothesis, there is an about 1 in 10 chance of observing this data or something more extreme. Another way to look at this result, though, is to draw a bell curve with the confidence intervals at each end. The bulk of the confidence intervals of 0.61 to 1.05 would fall under the less than 1 marker, suggesting some degree of true benefit. In fact, if this was analyzed in the same way that the anticoagulation in COVID-19 study that I discussed last week was analyzed with Bayesian probabilities, we would say that the probability of any stroke reduction with the ILR group was pretty high. But here's the problem. Major bleeding was also increased by about the same amount, 4.3% versus 3.5% respectively. And here the hazard ratio was 1.26, so a 26% increase in major bleeding, and the confidence intervals range from 0.95 to 1.69. So again, the bulk of the confidence intervals range is above 1, suggesting some degree of harm from the extra anticoagulation. So it sort of seemed like a wash. But I don't think that's all we should say. Here's a few more comments. The ILR monitoring is the ultimate AFib monitor. Unlike an Apple Watch or spot checks, ILR is always on. In Loop, the authors were careful to adjudicate each episode, so it's likely the false positive rate was quite low as well. And since stroke reduction was non-significant and bleeding rates were also increased, I think this study clearly closes the chapter on using these super expensive ILR monitors to screen for AFib. But there's also some nuance here that is worth mentioning, because the issue of how much AFib warrants anticoagulation is like the number one question in all of cardiology. I'm asked it almost every day. The authors of Loop use 6 minutes of AFib to trigger anticoagulation, but that's probably too low. Remember, in the ASSERT observational study of cardiac device patients, 6 minutes of AFib did associate with a 2.5x higher risk of stroke, but nearly all of that increased risk stemmed from longer duration episodes of greater than 24 hours. So I wonder whether a higher threshold of AFib might have had a bigger effect on stroke reduction with less major bleeding. I say that because the patients in Loop may have had too many vascular risk factors to benefit from anticoagulation. Here's a super important nugget, one that is often forgotten by AFib doctors, especially those that favor percutaneous closure of the appendage. The point is that AFib is not the most common cause of ischemic stroke. It's a bit like the heart failure hospitalizations versus total hospitalization point I just made. Reducing AFib-related stroke may not have a major impact on patients with oodles of vascular risk factors, because for these patients, AFib-related stroke maybe represents a small proportion of the reasons for total strokes. Now, I'm not saying that I know the sweet spot of who to use oral anticoagulation in, but recall that in the seminal trials of anticoagulation, like the warfarin trials, only patients with clinical AFib diagnosed on a 12-lead ECG that was done for some reason were randomized. And the lack of ability to screen for AFib with wearable devices back in the days may have enriched those seminal trials with patients most likely to benefit from anticoagulation. Well, the good news is that there are ongoing trials looking at anticoagulation for subclinical AFib, and we're going to learn more about that threshold. And as wearables expand, we will also learn how much AFib occurs as the normal part of the aging process. For now, it will have to be judgment in the use of anticoagulations. Finally, I think the Loop study beautifully confirms how hard it is to show that preventive screening works in real life. Remember, screening icons, Drs. Wilson and Younger, called this as early as the 1960s. Basically, they said that screening for disease is admirable, but in real life there are snags. Indeed, real-world practice is full up of snags. Third trial I want to talk about, and I think is just amazing, is Ablate and Pace. The Apaf-CRT trial compared CRT pacing and AV node ablation versus rate control in patients who had symptomatic permanent AFib that was unsuitable for primary AF ablation or AF ablation had failed. These patients also had a narrow QRS and at least one hospitalization for heart failure. This trial delivered truly stunning results. Now, we all know who these patients are who were enrolled, right? Older, often female, small stiff ventricles, difficult to control ventricular rate, tons of medication, soft blood pressure, and severe dyspnea. AFib ablation would be foolish in these patients because A, it wouldn't work, and B, the procedural risk is too high. Now, whereas most patients with AFib benefit from reassurance, treatment of risk factors, going slowly, patients like those in Apaf-CRT trial need action. In essence, these patients are dying from AFib, emphasis on from. Apaf-CRT was a two-phase trial, and in 2018, the investigators reported morbidity outcomes. And in this paper, CRT ablation was superior to medical therapy in reducing heart failure hospitalizations and quality of life. And at ESC, they presented and published in the European Heart Journal the second phase, the heart outcomes phase. Apaf-CRT found a 74% reduction in death with CRT and AV node ablation. After 29 months of follow-up, 7 of 63 patients in the CRT ablation arm died versus 20 of 70 patients in the drug arm. This was 11% versus 29%, a hazard ratio of 0.26, with confidence intervals 0.10 to 0.65. Keep in mind, too, that mortality is the most bias-free endpoint. This is even more impressive given that 18 of the 70 patients in the medical arm crossed over to receive CRT and node ablation, but by the intention to treat analysis, they were still counted in the medical arm. Ejection fraction did not modify the results. The benefits of Ablate and Pace were equally good in those with normal and abnormal EFs. I'm not sure why this trial didn't get huge attention. A 74% reduction in death is amazing. Now, perhaps it is because right now in electrophysiology, the climate is so unthinkingly enthusiastic about AF ablation. Perhaps if you get too excited about node ablation and pacing, it's as if you're going to get a call from the AF ablation police. I think this is wrong, and I believe the results. I believe the results because these patients are dying from AFib. Many have these small, stiff ventricles. They do terrible with rapid, irregular rates. Mechanical rate control with ablation, it regularizes the rate, it obviates the need for high doses of medications, and the CRT part prevents the left ventricular dyssynchrony that can accompany RV-only pacing. I don't think we should be creating AV block and pacer dependent willy-nilly. This requires thought. But this procedure offers these patients huge relief, and now we can say a mortality benefit. I work in a very regular, everyday private practice world, and we see a lot of patients like those in Apaf-CRT. And I've used the Ablate and Pace strategy often. Kudos to the investigators. The next step, I think, is to study node ablation with bi-V pacing versus left bundle branch area pacing. The latter, left bundle pacing, if successful, could achieve CRT with one lead instead of two. The final study today is the salt substitute and stroke study, so-called SAS study. Now, no matter where you fall on the salt debate, three things are clear. Elevated salt intake and low potassium intake associates with high blood pressure. Salt reduction can reduce blood pressure, and lower blood pressure surely associates with lower rates of stroke. Now, salt substitutes that replace part of the 100% sodium content of salt with potassium chloride content work in two ways. They simultaneously reduce sodium intake and boost potassium intake, and studies have shown that salt substitutes can reduce blood pressure. The question the SAS trialist asked is whether this translates to a reduction in heart outcomes, stroke, and major adverse cardiac events, MACE. And yes, it did. But before I tell you the results, I want to tell you about this study. It's such an interesting study design. It was conducted in rural counties in China. This is important because in these areas, most of the sodium intake comes from added salt in cooking. There are no significant amounts of processed food, which is high in sodium in these areas. That fact allows for a study of salt substitutes. It would be much harder to study this in North America because here the majority of our salt intake comes from processed food, not so much cooking or seasoning. Sufficient salt substitutes were provided to cover all household cooking and food preservation requirements at an average of approximately 20 grams per person per day. The investigators, however, did not randomize individuals, they randomized entire villages. 300 villages were given the salt substitute, 75-25, sodium-potassium, and 300 villages stayed with the normal cooking routine. They then chose 35 individuals per village, about 10,000 patients in each group. Now, these were pretty high-risk patients. About 3 in 4 patients had a history of prior stroke, 88% were hypertensive at baseline, and follow-up was at 5 years. The mean blood pressure reduction was 3.3 millimeters of mercury. Urinary sodium excretion was lower. Urinary potassium excretion was higher in the active arm. Here's the results. The rate of fatal or non-fatal stroke events was significantly lower in the salt substitute group than in the regular salt group. It was 29.1 versus 33.6 events per 1,000 person years. That's a 14% relative risk reduction that was statistically significant. There was also a statistically significant reductions in major adverse cardiac events, 13%, and all-cause death, 12%. Safety was assessed by hyperkalemia, and here there were no significant differences in the two groups. I spoke with the primary author, Professor Bruce Neal from the University of New South Wales in Australia, and we'll have a video coming up on the Heart.org Medscape Cardiology. He assured me that despite this being in rural China, follow-up was nearly complete, greater than 99%, and interestingly, he pointed to the national healthcare system in China as one reason you could get such strong follow-up, with almost no loss to follow-up. I also asked him about the mean blood pressure reduction of just 3.3 millimeters of mercury. How did this translate into such big gains? And he reminded me that this degree of blood pressure reduction in high-risk patients can make a big difference, and it wasn't far off what we get with some blood pressure drugs. I've been thinking more about this trial since our chat, and I guess it doesn't really matter as much about the blood pressure reduction if the intervention works to reduce stroke. Recall, my friends, that blood pressure isn't a disease. It's only a surrogate marker. Now, while the absolute risk reduction in outcomes were modest, if you apply this to populations, this trial is a huge deal. The authors remind us in their discussion section that the prevented strokes, cardiac events, and deaths with this intervention could number in the hundreds of thousands. I think it has huge policy implications for the food industry. Imagine if the food processing industry moved to use salt substitute. It could have a massive effect on population health. I asked Dr. Neal about the taste issue, and he said that at about 25% potassium chloride, it approaches the level of noticing it, but patients in his trial tolerated it just fine. Again, congratulations to the authors of this paper. This really is an amazing trial. So that's all I can cover this week. I've already been talking for more than 20 minutes. Next week, we'll cover 4 to 5 more ESC trials. There is more to say, but I wanted to split it up into 2 podcasts. A final note before I close. Remember, my friends, there's a lot of podcasts out there. If you like this podcast, it really helps if you could take the time to give us a rating, write us a 1 or 2 sentence review. This helps others find us. We're up to 401 ratings on Apple Podcasts, and that's great, and I really appreciate the support. Thank you. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.